We'll be moving on now to Protocol 9, which is the Rehabilitation for Responder Protocol. This is a general guideline for rehab during fire department operations. You have age-predicted maximum heart rates on the top right corner. Also, you have indications for our advanced providers as when to initiate fluid resuscitation to the providers. So it is your responsibility to become very familiar with this protocol. In this protocol, for our advanced providers, we're going to talk about orthostatic vitals changes. Orthostatic vitals is a increase in your pulse rate greater than 20 beats a minute upon standing, and a decrease in your systolic blood pressure greater than 20 millimeters of mercury drop upon standing. If this is the case for our advanced providers, we want to infuse up to 2 liters of normal saline until the heart rate is less than or equal to 100 and the systolic blood pressure is greater than or equal to 110 millimeters of mercury. Protocol 10 is the spinal immobilization clearance protocol. This protocol is a great guide to when and when not to backboard a patient. And this protocol falls under all provider levels. However, in the very young and the very old, a normal exam may not be sufficient enough to rule out a spinal injury. Your default is always to immobilize. If you have any doubt, immobilize your patient with a long board and cervical immobilization devices in place. Okay, so for our spinal immobilization clearance, there is an acronym that's going to help you do the assessment on your patient. And we've talked a little bit about this term NSAIDs before, which we said stood for non-steroidal anti-inflammatory drugs. But in this protocol, we're going to use it as an acronym for our assessment. The N stands for the neurological exam. Look for focal deficits such as tingling, reduced strength, or numbness in the extremity. The S stands for significant mechanism or extreme age, and that is extremely young or extremely old. Of course, if there's a significant mechanism of injury, we always default to immobilize. The A is alertness. Is the patient oriented to person, place, time, and event? Any changes in alertness with incident? Was there a loss of consciousness? Intoxication. Is there any indication that a person is intoxicated, impaired, they can't make decisions for themselves? Distracting injuries. Is there any other injury producing pain in the patient? Any injury which the patient seems to focus on more, such as a rating of 6 on a scale of 0 to 10 on the pain scale? That would be considered a distracting injury. And the S is spinal exam. Look for point tenderness when you palpate the patient's spine. Also, with range of motion, if they move their head and say it hurts. Each of the 7 cervical spinal processes must be palpated during an exam. So if the answer to any of these questions is yes, then we immediately immobilize the patient. If the answer is no to all of these assessment tools, then the patient can be cleared for the need of a spinal immobilization. Okay, Protocol 11 is our airway protocol. And when we look at this protocol, it is a general guidelines for basic airway maneuvers and, of course, for the E and A level providers, the EMT and the advanced level providers, the blind insertion airway device, and we are using, of course, the King Airway. Protocol 12 is an airway failed protocol. The biggest thing to remember in here is 2 failed intubation attempts by the most proficient technician on scene or anatomy inconsistent with intubation attempts. If there are 2 failed intubation attempts, your job as an EMT or an advanced provider is to be prepared with a King Airway. Once again, like I said, airways failed to intubation, be ready with a King Airway to secure that advanced airway. Okay, cardiac arrest, asystole, PEA, adult. There is no change from your current protocols. Of course, at the advanced level, all cardiac arrest algorithms are covered by the Advanced Cardiac Life Support Guidelines, and we do follow all of those in Fauquier County. A few things to remember with cardiac arrest, asystole, and PEA. Any provider needs to think about what the cause of the arrest is. You need to remember your H's and your T's. Consider all possible causes listed in the differential. Survival is based on how quickly we can identify and correct the cause. So, discussions with medical control is a great option. Cardiac arrest, asystole, PEA, again, no real change from your current protocols. Remember that at any time, a return of spontaneous circulation, we go to the appropriate protocol. We do have, and it's coming shortly, the post-resuscitative care protocol. And here it is, Protocol 15. This is post-resuscitative care adult. If there is not an advanced airway in place already, we do want to, if the patient does not have a gag reflex, we want to obtain airway access with our blind insertion airway device, or our King airway. Okay, so this protocol really just gives guidance to the provider when the patient obtains a return of spontaneous circulation. For all provider levels, the blind insertion airway device or the King airway should be inserted if not already completed. And the advanced provider up, we need to maintain a systolic blood pressure of 90 millimeters of mercury. If it is lower, establish IV. Normal saline bolus is 30 milliliters per kilogram to a max of 2 liters. All right, Protocol 16, the post-resuscitation care pediatric protocol. This protocol is really heavily based on what the level of blood sugar is for the patient. So we do need to do an appropriate assessment, obtain a glucose reading on our patient, and if they are hypoglycemic, we exit to the appropriate protocol. Protocol 17, ventricular fibrillation, ventricular tachycardia adult. No real change from your current protocols. Protocol 18, same, ventricular fibrillation, ventricular tachycardia pediatric, and again, there has been no change from your current protocol.